Good morning. I'm here today and I'm happy to present to you on evolving techniques in closed tip rhinoplasty. My practice has evolved to one in which I'm doing majority of my cases of rhinoplasty cases through a closed approach. I think that this is the wave of the future, and I want to tell you a little bit about why I think that and give you some of my insights and tips into how I've made the closed rhinoplasty a procedure in which my success rate has been so high. So, rhinoplasty overall is one of the most difficult procedures to do well, and we all know that as plastic surgeons. Clearly, of all plastic surgery, there's no argument. Rhinoplasty takes the most amount of technical skill. Revision rates are reported somewhere between 4 and 7%, but as we all know, these are largely unreported because many times there are people who are occasional rhinoplasty surgeons, and it's unfortunate, but there's those who only do an occasional rhinoplasty, and their revision rates are much higher because they run into a lot more problems, in my opinion. And in fact, if you look at the data from the American Society of Aesthetic Plastic Surgeons, the average plastic surgeon does only about 14 rhinoplasties a year, which I think is an awfully low number, and those are from plastic surgeons. So I think that someone who's doing that few rhinoplasties is more likely to have some difficulties because this is such a technically oriented procedure and experience does matter. So likely revision rates are underreported from what they really are. I would bet they're somewhere in the 30 to 40% range if all patients who had rhinoplasty were considered. So I want to talk about, I think, the basis of rhinoplasty. And here's a lady that I think exemplifies my next point. I did rhinoplasty on her. This is her frontal view. Overall, very nice result from what I'm sure most of you would agree. Lateral view, also a very nice result. But do you think this patient's happy with her outcome? Do you think this is what she wants? Well, the truth is no. She wants her nose to be smaller. She's requesting her nose to be smaller. Here's another patient that I treated. Overall, nice result, but when I look at it, I see a few things that could be better. But she's a difficult nose. But she's thrilled with her outcome. She thinks she's got the best rhinoplasty that she could ever have. She's so happy and doesn't want to change a thing. Whereas the other patient I showed you would like changes, wants her nose smaller. This lady's happy. So what's the difference? Why is one so happy and another one's not? I think we have to realize something. In cosmetic medicine, the key is patient satisfaction. It's not what we want, it's what the patient wants. And we have to be very careful to read the patient and to give them what they want. And I think that this pertains to closed rhinoplasty because I think today patients want less. Less is more. And I think this is important when it comes to making our patients happy and to having successful practices and happy patients. So the external versus the endonasal approach. I'm going to tie this all together. The external approach is a wonderful approach. You can see great. You can make terrific changes, especially in a deviated nose. And the endonasal approach is a nice approach also for a different candidate. And sometimes there's a clear advantage in the external approach. For instance, someone like this gentleman, this young boy, there's no way I'm going to get him straighter through a closed approach. He's got a lot of difficulties, a lot of deviation in his middle wall. He's got a wide nasal base. He's got a wide nasal pyramid. There's just no way that I can get his nose straight and improved unless I do it open. So I did him open, and he has a very nice result. There's lots of room to work and see, and he's able to look a lot better. But clearly we have to admit that the open approach seems to have a longer recovery period. And I think a lot of that goes with the fact because we're deconstructing the nose before we reconstruct it. When we open the nose, not only are we making an incision in the columella, which by itself is not that much of a change from the closed rhinoplasty, but by making that incision and flipping the skin up over the nasal tip and exposing the nasal cartilages, I think we're removing some of the key structures to the nose, and one in which I think we're causing the nose to be weakened in some respects. And we're taking cartilages apart, we're taking away important attachments. And once we do that, we have to spend a lot of time putting the nose back together. So there's a tendency to do more because we're adding a lot more grafts. And in general, the surgical time is longer because it takes a little bit longer to put all these grafts in and to get the correct exact result that we'd like. So we're constantly putting the skin up and putting the skin down. I think all these things lead to a little bit more edema, a little bit more swelling. There's also a little bit more bleeding because the longer you take, the epinephrine and the local starting to wear off, so you may get a little more bruising. So I think this leads to a longer recovery period. And I think there's another issue with the open rhinoplasty because it's not the open rhinoplasty per se that's causing these issues. It's the fact that when we go in and do an open rhinoplasty, we're changing the nose so much that afterwards the nose becomes a different nose. It deviates much further from what the nose originally was. It's much further from the context of the patient's face. And occasionally patients will complain their nose feels numb and hard. And it can take a long time for them to get the feeling back. It's uncompromising when they kiss. They may not move when they animate. Sometimes patients complain it doesn't feel natural. And I've never had a patient yet who said to me, "Doctor, I really want my nose to be bigger." They all want their nose to be smaller. So there's a lot of hand-holding because you have to walk these patients through a time period until their nose starts to look and feel more natural. And I think there's extremely greater difficulties when this procedure is done by a novice. When the fellows just graduate and they start doing open procedures, their mentors, their fellowship directors make it look so easy. But the truth is that they can get into a lot more trouble, and the defects they can create are even more difficult to fix than if they went through a closed approach. Now, although oftentimes when we do an open approach, the pictures look great, the nose may not appear as natural in real life. Now, in contrast, when we do an endonasal approach, the nose usually looks good immediately. 1 week later, the nose looks great. You take the splint off, patients are happy, it's thin, they're going right back to their normal routine, happy patients. Whereas the open approach, it's usually taking weeks before they're happy. Last year, we did a survey. We reviewed all the graduating fellows from the American Academy of Facial Plastics, and we asked last 10 years of fellows, how often are you doing open rhinoplasty in your practice? And what did you most commonly learn in fellowship? And what we found was that 88% of the time, 88% of the fellows were doing open rhinoplasty. These are first-year graduates. 88% of them were doing open rhinoplasty greater than 50% of the time. Or, I mean, these were graduates within the last 10 years. So within 10 years of graduating from fellowship. And over 75% of the time, these graduates, 72% of them, were doing an open rhinoplasty. And it doesn't surprise me that the majority of the recent graduates doing open rhinoplasty, because that's what they learned in fellowship. Because when we asked them how many of them were learning open rhinoplasty, what was the breakdown in fellowship, over 83% of them said the most common procedure they learned, the most common approach to rhinoplasty was the open approach. So the open approach was taught to the majority of these fellows, and they're going out and they're doing a majority of open rhinoplasty. So the point I was looking at, what I was identifying here, is that most trained graduates now from approved fellowship programs are learning primarily the open approach, and a lot less often are learning the closed approach. So my question is, has the pendulum swung too far? Certainly the open rhinoplasty is a good approach for many, but is it indicated that often? Aren't there many patients who would be good candidates for the closed rhinoplasty? And why are these trainees not learning it? Well, there's many reasons for it, and we could speculate, but that's not the core of this lecture. But you have to realize that most of our fellowship programs are centered in tertiary centers, and these type of physicians are getting a lot of difficult rhinoplasties that may require open rhinoplasty. But I'm sure that out in the community, when these fellows graduate, there's a lot of patients out there who can benefit from a closed rhinoplasty and don't need as much surgery as they may be getting with an open.